Let me introduce Craig Buchman. Craig and I go back many years when Craig was a medical student in Florida and I was a resident in Florida, and we've crossed paths so many times during this time. Wonderful individual, good friend, and great academician, and very proud that we can actually introduce Craig today. Craig's actually the chair of the Department of Otolaryngology at Washington University in St. Louis. And he's graciously agreed to give us a talk on adult cochlear implant candidacy. So Craig, thank you for joining us today.
Hey, thanks, Bill. Thanks for having me. It's certainly an honor and a lot of fun to be able to interact with you and Dr. House and the rest of the crew there over the many years. I remember my days there really fondly, often talk about it with friends. So what I'm going to try and do today actually is cover candidacy. And the reason I thought it was a good topic, it can be a bit dry, so bear with me if it feels a little dry, but I think it's important to think about where we are today in candidacy and sort of where we're going. And the other part of candidacy, which I think is important, is trying to understand who's going to do well with a cochlear implant. And I know that a lot of this sort of is based in audiology stuff. So that's why I say bear with me if you find it a little bit dry, but it's also important to recognize how we're making decisions. And this has implications for insurance and payment. So all of you all that are going out into practice, this will be front and center. These are my disclosures. None of them is really related to this particular talk, but I put it out there just so you know. So as everybody knows, hearing loss is super common, about 40 million affected in the United States, a little bit bigger now. That's 2012 data. And about 1.5 million are thought to be severe to profound. Each of these buckets comes from a different group, but different data source. But about 1.5 are thought to be severe to profound, and about 100,000 cochlear implant recipients. And so, you know, roughly less than 10% of adults that are candidates are actually getting the device, and maybe 30 to 40% of children that are candidates are actually getting the device. So that's the sad story about cochlear implantation, and it probably boils down to awareness more than anything. It's probably not a payer issue. It's probably an awareness issue not only with patients but also with general medical types, as well as otolaryngologists, frankly, and audiologists. There's some other issues that are at play, but the big one is awareness. So about 40 million, as I said, in the United States. The big chunk of those are noise-induced hearing loss. You know, there's probably 26 million. It's the most common issue that pops up from the military, second only to tinnitus in the military. And upwards of 50% of people over age 75 have it. And then the ones that we're used to in our practices, you know, these are relatively low number items, right? Meniere's disease, sudden deafness, or, you know, sudden hearing loss, and acoustic tumor. So just to keep all those things in perspective, the big nut out there is going to be noise-induced hearing loss, age-related hearing loss, and some genetic component that plays into that. And that's probably most of the patients that are out there. And as we all know, hearing loss is a big deal, but it's not easily recognized. And so it causes problems with sound awareness and communication abilities. And for adults, you know, this usually translates into social isolation, depression, and we all are aware now of the implications regarding cognitive decline. So this is so what do we know about cochlear implants? And the bottom line is that they work. So our real job is to figure out who to get them to, and to do it in a high quality manner, because cochlear implants almost never you know, give no sound awareness. So almost all the time people can hear something unless there's something really bizarre. They improve lip reading and speech understanding. About 70% of people can talk on the phone. I like this this graph. This is from Margot Skinner's work, actually. And what it shows is that amongst clear-cut group of 15 cochlear implant candidates that all met criteria, there's a super wide range of performance. You see all the way from getting almost nothing in CNC word scores almost up to 100%. So amongst a good group of candidates, there's wide variability in performance. And this is part of the frustration, is that when you sit in front of a patient, you can tell them that they're a candidate, but you can't tell them that they're going to do well. Because that's the one thing they want to know is, am I going to do well? And the answer, at least from a speech perception standpoint, is I don't know. But if you want to ask them, are you a cochlear, if they ask you, am I a cochlear implant candidate, you can pretty definitively say yes. And so, and we talk about returning to employment, social isolation, you know, the cognitive issues, but that data is sort of emerging over time. So, you know, what would you think matters regarding performance? And you would guess all these, but the reason I put this up here is, you know, there are peripheral and central factors. The peripheral factors, you would guess that the better your cochlear nerve, the better you would do. But our surrogate marker for that when we talk to patients is etiology and duration of hearing loss. When we ask them how long has their hearing loss been there, or what the, you know, trying to sort or figure out what the cause is, that's sort of our surrogate marker for neural substrate. So we don't really have a good test for that. And then, of course, the device being in the cochlea is better than not in the cochlea. And I hope all of you fellows can figure out how to do that properly. And then there's some issues with electrode design, of course, and mapping does matter. It's important to have good audibility. If you're mapped poorly, then you're not going to hear well. And then the stimulation paradigm presumably matters. And in the best world, we'd be matching that to normal function. And then there's central factors as well. Obviously, that has to do with what the functional substrate is. And again, we use as a surrogate for that sort of duration of deafness and duration of use of the device. But the truth is, again, we don't have a great measure for that. And we always think about plasticity as well. So what do we know? This is, again, from that Margot Skinner, that wide range of performances that you saw. And these are the factors that are statistically significant. So you would say to yourself, you know, is age and implantation matters, duration of hearing loss, duration of hearing aid use, duration of severe profound hearing loss. All of these have been shown to be statistically important factors and significant factors. And then cognitive ability, pure tone average with the device. So this is that mapping thing we were talking about, electrode being positioned in the cochlea. And each of these factors are sort of those that I just showed you on that screen. They generally give us a sense of, or we believe that they're surrogate markers for the neural substrate, the degree of sort of neural degeneration over time, and mapping an electrode position. But the one thing that hasn't been tested is postoperative residual hearing. I sort of harp on that because I think that that might be a good surrogate marker for a very atraumatic cochlear implant. So, but with that being said, you'd say to yourself, okay, well, that's pretty good. But this study by Lazard, which is one of the groups from Melbourne, they put this information out there, and they looked at, again, these various variables, and looked at the impact of these variables on performance. And I think the important thing to recognize is that while many of these, which are the same ones that I just showed you, are statistically significant, if you take all of them together, they only account for 22% of that variance that I showed you in that Skinner graph. So what it's telling you is that despite the fact that each of these things that I'm showing you here are important and statistically important, the magnitude of their impact is really, 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 really small. So that the issue is that what that basically tells us is that someone that walks in the door, we take our history, our physical, we do all the things that we do, but when that patient's sitting in front of us, we still actually can't tell them how well they're going to do. We can just tell them that they're a candidate or not, and we'll get to that. So as I said another way, we really don't know who will have good cochlear implant performance, and residual hearing hasn't been studied. So remember that as you're talking to patients. You can certainly tell them that they're a candidate, but you can't tell them if they're going to do well. Now, there might be that sixth sense that some master clinicians can figure out, you know, Dr. House and Slattery and others, that you have this sense that this person's going to do well, but the truth is we don't definitively know that talking to them. So we need to explore new variables. One of the things that's out there, and I'm just going to have one slide on this, is electrocochleography. The only reason I put it here is just to say that with this kind of testing, and we were doing this in the operating room, that if you look at CNC word score versus the total response, and I won't get into the details of this, it's actually pretty darn predictive of CNC word score. And so you can see that 46% of the variance can be explained by this single measure. So I think my point is that the variables that we use, duration of deafness, duration of hearing loss, how long you've worn your hearing aids, those are actually really not very good surrogate markers. But if we ultimately get to a place where we can do this kind of testing routinely, which we're certainly not there today, we can predict up to 46% of the variance. And if you add age, it goes well up above 50%. So that's just something to think about for the future. So the issue is, I'm going to talk a bit about candidacy criteria, and then we'll talk about sort of where things are going and expanding that candidacy platform. And much of this might be stuff that you already know, or it might be stuff that you're starting to see happen in practice. So this is what CMS will pay for. CMS is, of course, the Center for Medicare and Medicaid Services. So this is Medicare. And the criteria today are bilateral moderate to profound. So it's not severe to profound, it's moderate to profound sensory neural hearing loss. Patients need to do worse than 40% on open sentence material that's presented tape recorded. So it doesn't say that it has to be AZ Bio or Hint or CUNY or whatever. It just says tape recorded material of sentences. They've never really gone to words. That's something that we tried to push them on. But so the point is, the materials are not specified. The laterality, meaning if you did it in one ear or both ears, is not specified. And the addition of noise has not been specified. And we'll talk a bit about that. And then it could be between 40 and 60% on the same measures if it's done under an FDA or CMS approved trial. And I'll show you data from the trial that we have just finished up. And then cognitive abilities and middle ear issues. In fact, we oftentimes have patients that have each of these things, but they still end up getting their devices. So this is the labeling currently. So labeling is an FDA thing. CMS criteria is what Medicare will accept. So this is when the companies have a device, they do a study, and then they negotiate with the FDA what that device, what are the labeling for that device. Here's the three companies: Advanced Bionics, Cochlear, and MED-EL. These were the negotiated labels for their devices. And while they're roughly similar, they're not the same. And so the presentation level for the test materials is not specified for two of them. Cochlear, it was specified at 70, but commonly people are being tested at 60. And then you see sort of the different wording around these. Importantly, the scores for Advanced Bionics and Cochlear are the same, but for MED-EL, it's slightly less. So I've never actually had an insurance company push on us for that, but that's it. So typically today, AZ Bio sentences are being used, and typically today, less than 50% in the implant ear is the score that's out there. So what do we do in practice? For Medicare patients, again, we're shooting to get under the 40% best aided bar. This has been around for a long time. And so in the early parts of 2000, we were, before 2004, we were presenting the test materials at louder than 60 dB. We're probably somewhere around 70 dB. And then Jill first wrote a paper in 2004, which sort of pushed us all to drop back and start to test at 60 dB because it was felt to be a more typical sound level relative to how most people communicate, although my voice is a lot louder than that, of course. And then Renee Gifford later developed the AZ Bio sentences, which started to be used in lieu of hint sentences. AZ Bio sentences are harder than hint sentences because they use both male and female talkers, and there's a variety of both male and female talkers, and so and the sentences are a little bit tougher. So again, despite the fact that we still had that 40% bar, we reduced the presentation level from 70 to 60, which made it a little tougher. We changed the sentence material from hint sentences to AZ Bio sentences, which made it a little tougher. And then what happened literally over the last few years here is that Renee Gifford basically pressed us to start adding noise. I'll tell you that noise is a different bird, and we'll talk a little bit about that. But people started adding noise really to take candidates that were greater than 40% in best aided and really push them down into the less than 40% category. So in around 2012, John Naparco and myself and Terry Zwollen went to CMS to talk to them about doing an expanding indication study. And I'm going to show you the results of that study. But what happened, which you'll see, which has been frustrating, is that we opened this study around 2014, and Renee and many people from around the country started testing in noise really right around that time as well. And so it became very, very difficult to get patients into the study because people that would normally be 50 or maybe even 60% on best aided AZ biosentences were being qualified less than 40. And so this 41 to 60 criteria is for AZ biosentences in quiet. So there's been some trepidation about the results of this study and people being nervous about it. So this is the study that that was put together, and we call it the expanding indication study. CMS actually sponsored it. So what that means is that they allowed us to operate on patients with AZ biosentences between 41 and 60%. These are the groups that signed on, although we sent out to try and get patients from all over the country. And it took us a number of years to accrue, you can see, to accrue the data and get 12-month follow-up. So we have 32 patients, and we recently presented this to CMS, and they very much liked it. So I suspect that this is going to move forward. I'll show you the details here, and it's currently submitted to the journal. So this shows patients that come to the clinic and are tested in their best aided condition, meaning 2 hearing aids preoperatively, and then postoperatively as a hearing aid in their one ear and a cochlear implant in the other. And their preoperative AZ biosentence score was somewhere between 40 and 60% correct. And then they underwent routine cochlear implantation at the center. There was all devices were present in the study. And you can see the red line here is the group that started at between 40 and 50, and the green line are those that started between 50 and 60 AZ bioquiet in their best aided condition. And then you see after cochlear implantation, by 6 months, they had a statistically significant improvement. It's significant because these are confidence intervals, not just error bars. And so the lack of overlap of these error bar or these confidence intervals with these tell you that it's statistically significant. You can also see that these are all positive numbers. The other thing is that, which I think for the fellows out there, is that generally speaking, if people are going to get a big improvement, it happens in the first 6 months. In fact, maybe 80% of the gain happens by about 3 months. So if you're seeing a patient at 6 months after a cochlear implant, much of their improvement has occurred. So I think that's just important to recognize. The other thing about this group is that the cochlear implant ear was the worst hearing ear in most instances. So you can see their best aided was between 40 and 60, but many of these patients had one ear that was a little worse than the other. But in both instances, the CI ear alone and the best aided, they had really significant improvements in AZ biosentences. This is a CNC word score, so monosyllabic word scores rather than sentence material. CMS really likes sentences because they think it has some cognitive component to it. I'm not sure that it's really the best measure, but that's what they've always pushed us on. So we still gather CNC word scores, and similarly, you see big improvements in CNC word scores in the best aided condition as well as the CI alone. One of the other things that we negotiated with CMS about is they wanted a quality of life measure, and so we did the HUE-3. The HUE-3 has a number of domains that are in it. The 2 domains that moved were the hearing domain, not surprisingly. So patients had a big improvement in their hearing domain, as well as the HUE multi. You might look at this and say, wait, that doesn't look significant. It actually is. If you look at baseline versus 12 months, that's a significant improvement. All the other domains really didn't have much change in them. So significant improvement in quality of life as well as AZ Bio and CNC word scores. So, and then one of the questions that we had is, does the change in your speech perception as measured by the AZ Bio actually indicate that you're going to have a quality of life improvement, or are those 2 things separate? And lo and behold, there's actually pretty moderate correlations between the AZ Bio change, which is here on the x-axis, the change in the AZ Bio score in the implant ear versus their change in the HUE. And what you see is a pretty good correlation. The same thing can be said for the AFAB, which is another quality of life indicator as well. So that made us feel good. So, they're not completely disconnected. So people who get more of a change in their AZ Bio generally have a bigger improvement in their quality of life. So the summary of this is that cochlear implants are effective in the Medicare population between 41 and 60%. That's because we saw significant improvements in AZ bios as well as CNC words. There was also a telephone test that they had us do. Over 90% of the people improved in their telephone test as well. And then importantly, those measures of speech perception seem to be relatively correlated with quality of life. So all that made us happy. So this is the current verbiage around from Medicare, and we're suggesting the proposed change. So cochlear implants can be covered for treatment of bilateral pre or post linguistic sensorineural moderate to profound hearing loss in individuals who demonstrate limited benefit from amplification. Limited benefit from amplification is defined by test scores, and we're suggesting of less than 60% correct in the best aided listening condition on tape recorded tests of open set sentence recognition. So we're asking, so this verbiage is the exact verbiage that's currently out there today, except that we're suggesting that they change the number from 40 to 60. If this happened, I think the entire field would be happy with us, and we got our fingers crossed that it'll happen. All indications are that it probably will happen. There's still some work to do. We have to go through the process of what they call a national coverage determination to see if they'll make this change. But we've already presented the information to CMS. Terry and I did about 4 months ago. And so hopefully we'll be able to move the dial. The thing I worry about is really is the noise testing. And I think that's the issue, is that this whole noise testing thing has been here now for quite a while. If we use 60% as the correct number, but we don't specify anything around noise testing, the number of people that'll be qualified for a cochlear implant will go way up, and many of them actually will probably do poorer with a cochlear implant than they did with their hearing aids, because noise testing really evaluates something different. So I want to just talk a little bit about that. Just to, for the fellows out there, just to try and put these things together in your mind. AZ bio sentences, okay, are generally easier than CNC word scores, which are single words. And so this is that group of people that had both AZ bios and CNCs. For the most part, an AZ bio score between 40 and 60, which was the group of patients in this trial, is equivalent to you see a CNC score. So you get some sense of where these live. But there is quite a bit of variability in here. Okay, so I just want to talk a bit about noise testing. I think noise testing is really important to understand what it's doing to patients. Most centers, including ours, are qualifying Medicare patients by putting them in plus 10 dB signal to noise ratio. Some people are actually putting patients in plus 5. What that means is that when we talk about plus 10, plus 5, 0, what we're talking about is that the signal is 10 dB louder than the noise. So a signal to noise ratio means that the signal is 10 dB louder than noise. Plus 5 is that it's 5 dB louder, and 0 would be that the noise and the signal are equal. So this study was the CI 532 study that many of us participated in. And the entry criteria for this study was a CNC word score of less than 40% in the implant ear, and in the contralateral ear of less than 50. And all these patients, which was interesting, we forced them through a 30-day hearing aid trial, which we always talk about that, I think, in principle, but sort of in practice, it's oftentimes to get people through a detailed hearing aid trial before we consider them as a cochlear implant candidate. So a 30-day trial, and then ultimately went on to get a cochlear implant in one ear and wore their contralateral hearing aid. And then just so everybody knows what, these were all 532s. They were almost 90% ended up in scala tympani. There were 3 tip rollovers, which was early in the series, but there's very few translocations and really quite good placement. And this is sort of the kind of stuff that we see from our CT reconstructions on electrode location. So this was a group of nearly 100 patients that had really high quality surgery, the same device, mapped appropriately. And so this is, I think this is the kind of modern day results that we're now seeing. These are not all Medicare patients. These are, the mean age in this study was 71 years, but it's a pretty broad range. But this is what we're getting out of devices. So people are coming in with a CNC word score, you know, somewhere between 10 and 20, and the mean CNC word score is about 62. Remember that Holden study or the Margot Skinner work I showed you at the beginning, the mean score, 61.5. So what this tells you is today, what we're getting out of cochlear implants is roughly a 60% CNC word score on average. But look at the error bars, they're still pretty broad. So I think still that same issue of predicting how well someone will do is out there. So the common criteria that people are, oh, and just to say the obvious, because I think this is important, if you see someone with a CNC score of 10 to 20% after getting a cochlear implant, 93% of them will do better on that study. 93%. Same do the 7, and none of those patients do necessarily worse. So CNC words are a really good indicator, I think, of a patient's ability to do better. And I feel really confident if I see someone with this kind of CNC word score and they undergo a cochlear implant, I feel really good that they're going to do well. As that CNC score starts to get up here higher and higher, then you're starting to compete with sort of a ceiling effect. We don't see continually improving outcomes relative to the CNC score. So the more CNC you have is not necessarily the better that you do. So this shows AZ biosentences, and what you can see given at a plus 10 dB signal to noise ratio. And while you certainly see a significant improvement, the key thing here is that only about 3/4 of the patients do better, and 20% do the same, and about 7% do worse. So as you start to put people in background noise, it's not necessarily a clear indication that they're going to do better. So beware of using the AZ biosentence score in your mind as sort of a barometer of whether they're going to do better, especially at plus 10. And then even worse at plus 5, which this has become very common now, or this is modestly common across the United States. And what you see is if people come in and they have an AZ bio plus 5 of less than 10%, you think, wow, they can't really hear very well. But post-operatively, after getting a cochlear implant and wearing a hearing aid in the, well, this is just the cochlear implant alone, you see there's not a big change in plus 5, and only half of the patients can beat that score that they had preoperatively. So loud noise, plus 5 noise is really difficult for patients. And then this is the same data actually just for people wearing their hearing aid as well. A lot of people say, oh, if you put your contralateral hearing aid on, you'll be resistant to noise. And the answer is not really the truth. So what you see here is that people that struggle in noise after they get a cochlear implant, they struggle in noise as well. So for me, the best indicator of performance is what their CNC word score is. If their CNC word score is poor, they have a good chance of doing a lot better. If their AZ Bio plus 5 sentences is poor, it doesn't mean a whole lot to me, and I have a real tough time using that as an indicator. Yet that's how we're in many places. It's how we're classifying patients as cochlear implant candidates. So keep that in mind. And then this is sort of a slide I just pulled off, which I think is really important. It sort of shows the impact of noise on patients. And Matt Hsu, who's our fellow here, pulled out some of this data. But again, just to look here, and sorry, these are sort of typical statistics type software, so they're not very pretty graphs. But what you recognize is that patients in this same study, 96 patients, they come in, and this looks at patients. X-axis is time, the Y-axis is their CNC score, and then age less than 65 are those patients in red, and greater than 65 is in green. And what you see is for CNC word scores, basically these groups do the same. 95% confidence intervals overlap. So basically people that have a CNC word score that makes them a candidate, they tend to do similarly whether they're older or younger. But when you start to add background noise, what you see over here is that the elderly start to separate. And you see in plus 10 dB signal to noise ratio, they separate a fair amount. And if you go to plus 5, they separate an awful lot. So what it tells you here is that while their ear is probably a pretty darn good candidate for a cochlear implant, using background noise to qualify patients probably doesn't give you the true sense of how they can do. And so noise, susceptibility or resistance to noise is probably a more central factor rather than something that relates to how their cochlea works. And so I think you'll start to get the feel that my sense of noise testing is that it's really not a good way to qualify people. It's really not a good way for us as physicians and surgeons to have a sense of whether a patient is going to do well. So when they come into the clinic and they're tested at +10 and they do poorly, it certainly shows that they do poorly, but they might be more noise sensitive than they are a good or bad cochlear implant candidate. So, so again, noise testing is being used widely across the country to qualify patients that are Medicare patients. The elderly are clearly more susceptible to noise, and it's probably a central issue rather than a peripheral issue. And so I don't think it necessarily identifies good candidates, especially in the elderly. And I really believe that the CNC word score is probably going to be our best way to know if an ear is the right, is the right ear or a good ear to implant. So that's my shtick on noise here these days. And I think we're going to need a fair amount of change as we go forward. I do feel like there's some high risk if we move the bar from 40% up to 60% in the Medicare population, that people will start applying noise to people that do, that are doing 80% AZ bios just to qualify them. Those patients are going to do a lot worse with a cochlear implant. So just beware of these numbers as you're looking at it. So what do we do? Is there any question about Medicare? And then, or I can move forward here. I just thought that was worth a little extra time. Certainly have it.
Greg, it's John House again. And I think this noise factor is very important because we see patients with fairly good hearing. And as they get older, they begin to tell you more and more that they don't like noisy restaurants.
Yeah.
So that I think was an important point in your talk, is that as they age, they're not going to do as well in noise regardless.
Right. Yeah, our ability to filter out background noise, it certainly gets a lot worse as we get older. So. All right, and a lot of patients ask me commonly, and I'm sure you all too, is that they want to know how they're going to do in a restaurant. They want to know how they're going to do in a movie theater. They want to know how they're going to do at some other issue. And I usually tell them that honestly, in background noise, I think we all struggle, and the restaurant's about the toughest place that you're going to find. And if you get a cochlear implant, there's certainly some processing things that we can do, with hearing aids and cochlear implants to improve our performance in background noise, but getting the cochlear implant is not going to be the deal maker for them to improve in significant background noise. So that's important to know. So just to shift gears now to sort of the non-Medicare population, these are some of the things that I would say would be expanded indications these days. Certainly garden variety cochlear implant, and I showed you the FDA labeling that's out there. That would be very standard fare these days. But these are sort of some of the other areas that we're all starting to think more and more about. And in all of these cases, what we do is we see the patient, we look and see if they're a Medicare patient or a non-Medicare patient. If they're a non-Medicare patient, then basically we're submitting all of those for some degree of predetermination or authorization to try and get payment. And so these are some of the areas out there that are a little, can be a little bit tougher: hybrid or EAS, asymmetric hearing loss, single-sided deafness, tinnitus, and of course, tumor patients. And so I just wanted to talk a little bit about each of these to give you some sense of what's going on. And what you'll see is pretty much each of these things is showing a fair amount of effectiveness, but you might be stuck having to write letters to insurance companies to discuss their candidacy because they're not those mainstream CMS candidacy criteria. So I think all of you are aware of EAS. It's probably a relatively small niche that's out there, but the combination of wearing a cochlear implant that has an integrated hearing aid, so the signal, of course, hits the microphone, and then based on whether it's low frequencies or high frequencies, it's allocated to either an acoustic component or to a cochlear implant component. And as you all know, the basal aspects of the cochlea are important for high frequencies, and deeper in the cochlea is important for low frequencies. The device allocates either to the electrical or the acoustic side to provide that information. And so it's basically this part of the audiogram would be electric, this part of the audiogram would be acoustic. This requires some fairly sophisticated mapping to do this, and I would say that most programs are not really up to speed on it. So I would say that there's a lot of work to be done around this particular issue. The trial that we did while I was at UNC was an EAS. Was there a question? No? Okay. The trial that we did at UNC took patients that had CNC word scores of less than 50%, which is similar to that trial I just showed you before for the 532 study, and then extended it up to 60%. And in those patients, they had pure tones normal out to as good as 1500 hertz. So these are different patients than thinking about the cochlear implant patients that I'm showing you before. So just keep this sort of in your mind. These are people that have maybe low tones down as bad as 65 in the low frequencies, but many of these are these kind of audiograms. Okay, something up in here. So when you look at a patient in the clinic and they have a sloping audiogram, but their word rec is relatively poor, that's the kind of patient you're thinking about for EAS, not someone who walks in with low frequencies at 65 and then they fall off the chart. Your chances of being able to preserve that hearing go down, and your chances of being able to use the acoustic driver if you lose a lot of residual hearing is very, very low. So this was our results. This is a multi-center study, and what we found is about 12% of patients that entered the study went to profound, went to 90 dB, 12%, and this is across many different surgical platforms. So we thought that was pretty good. And about 80% had less than a 30 decibel hearing loss, and you can get a sense. Here's what they walked in with, and here's what they finished with after a year of having their devices in place. So modestly good hearing preservation. It's, on average, most people are losing around 30 decibels. So, and this sort of shows their CNC word scores, right? So you see their pre-op word score here using their hearing aids, and then here's their post-op score using their cochlear implant in the same ear as the amplification. And remember, just to put it in perspective, right? The Holden study and that 532 study, average performance was here, right? 62%. And you can see EAS gives you probably another 15 to 20% of performance in the operated ear. So this is certainly better than a CI alone. And then for those patients who lost a lot of their residual hearing, interestingly, in this particular trial, there were still some star performers, some that did just a little bit better and one person that did worse. People always ask, if you lose your hearing, how will you do? I pretty much believe that this has an awful lot to do with the length of the device. If you put a very, very short electrode in these people and then they lose their residual hearing, they don't get a lot of cochlear coverage, and that could be a problem. So this particular device had almost a between 270 and 360 in terms of angular insertion depth. So this was more like a normal cochlear implant. And then in a similar study, Tom Rowland and Bruce Gantz and a number of others. And the important thing about this particular study is this is ear-specific information, so not wearing a contralateral hearing aid. The hybrid trial, which was done by Tom and Bruce and others, this study used a contralateral hearing aid. So what they're comparing here is CNC word scores, okay, with bilateral hearing aids. So you see these numbers are slightly better. And then what you see is the post-operative results, around almost upwards of 80% post-operative CNC word scores. And then if you look at testing at +5, remember, this is what we were looking at in that other study before, average post-operative AZ Bio +5 scores are around 20 or maybe 30% at best. And you can see that using a cochlear implant in the hearing aid in one ear and a hearing aid in the opposite ear gives you far superior results. Now, these are patients that are walking in with a lot more residual hearing to begin with, but it gives you some sense of noise resistance. So adding a cochlear implant to a hearing aid in these patients actually makes an awful lot of difference. So EAS certainly is possible in adults, and it improves speech perception in both quiet and in noise a lot. And it does it whether you're wearing a contralateral hearing aid or not. I think the question that still remains to be answered is EAS better than a cochlear implant in one ear and a hearing aid in the other? And that study actually has not been done. So the question is that you take an EAS candidate with a lot of great residual hearing. If you put a cochlear implant in them and lose all their residual hearing, I showed you just a few patients out there, but the question is are those patients going to do better or worse than the EAS candidate? So EAS versus the CI alone. I think that's still out there to be answered. And the real issue is that when hearing preservation is completely reliable, where we can tell families with better than 90% that we're going to save the hearing, I think it completely changes the paradigm for both adults actually and children, because a lot of people, they're seriously worried about losing their residual hearing from surgery. And so that'll be a game changer. Just a brief issue on hearing loss. I mean, a lot of us don't, or many of us are interested in trying to understand why cochlear implantation results in loss of residual hearing. And here's a whole laundry list of things. I mean, it's always been remarkable to me just to look at this cross section of scale of tympani and look at how much volume a contour advance electrode takes up. Even if you were to put a hearing preservation electrode in, it still takes up, probably at least half to upwards of a half of the cross-sectional area. So it's a lot of plastic inside a very delicate structure. So it's probably not too surprising that we see changes. And as we get out near the basilar membrane, this plastic can interact with the basilar membrane and cause a, sort of an inner ear dampening. And then of course we worry an awful lot about fibrosis and scar. Bruce actually had a patient some years ago that had hybrid surgery, and then ultimately progressively lost their hearing over the next few years. And then they were fortunate to get his temporal bones and submit them to the Mass Eye and Ear temporal bone collection, and they processed them. And what's cool is that here's the unimplanted ear and the implanted ear after Bruce did surgery. And what you see is in the middle turns the organ of Corti in both the implanted and unimplanted, or the implanted ear and unimplanted ear, looks undisturbed. So despite the fact that the patient had progressive hearing loss, the organ of Corti didn't deteriorate. So that's sort of interesting. And if you look more closely at this particular case, what you see is that the scala tympani this is where the electrode used to sit. The scala tympani is completely filled with fibrosis, as well as some of vestibuli as well, and you see collapse of Reiser's membrane. And so the theory here is that inserting the electrode obviously caused some trauma and then some inflammation, which caused some degree of fixation of the inner ear structures. And so it's probably some sort of I don't know what the right term is, maybe an inner ear conductive loss or an inner ear fixation of the structures, and ultimately, had progressive loss of hearing. So I think more to be learned here. So shifting gears over the last few minutes here to talk about asymmetric hearing loss. So in contrast to hybrid, this is more conventional subjects that present with really different differences in their two ears, but hearing loss in both ears. And Jill First here at WashU has worked on this topic for quite a number of years. And we had this trial that's been ongoing for some time. Many Medicare patients as well. And so she took a group of patients that had this sort of asymmetry. You can see their preoperative audiograms, so you get a sense for the degree of asymmetry. And the line, of course, is the dark line's the mean there. And this looks at after receiving a cochlear implant. This is their aided detection audiogram, which is not so surprising. It just tells you that this was their better ear wearing the hearing aid, and then this is what a cochlear implant can do for audibility if it's appropriately mapped. And importantly, again, you guys are probably becoming experts now on CNC word scores, but in this particular group, in the better ear, so this is the unimplanted hearing aid ear, they're getting CNC word scores around 75%. And then in the CI alone ear, maybe a little lower than what we're used to seeing. This is in the 50s. Remember our number, 62%, right? That's the number you have to have sort of cemented in your mind as to what we see with a cochlear implant these days. But so this is what a cochlear implant did, right ear, or the implant ear, roughly in the 50s. unimplanted ear or the hearing aid ear, roughly in the 70s. This looks at their ability to hear in noise. And the thing to recognize here, lower signal to noise ratios is louder noise relative to the signal, right? In the better ear, you can see their percent correct on this particular test. And then you see what the CI ear does, right? So the CI ear is not going to perform as well in noise as their acoustic ear. But when you add the two ears together, they do significantly better as well. So bimodal hearing, CI in one ear, hearing aid in the other, in patients that present with asymmetric, allows them to do a lot better than either of the two ears alone. And then sound localization, similarly, again, RMS error is the root mean square error. It's your ability to identify a target for sound localization. And again, smaller numbers are better here, meaning less, less distance or less degrees between the target and where you guessed. And so you see CI ear alone, not super good performance, better ear alone, not super good performance, but if you add the two together, quite a bit better. And so two ears is definitely better than one when it comes to sound localization and hearing and noise, and adding a cochlear implant to a bad ear in the setting of another ear that has some hearing loss is advantageous. So asymmetric patients, especially if they have an ear that's a clear-cut cochlear implant, I would definitely go for that. So this looks at single-sided hearing loss or single-sided deafness. And there's a number of works out there. I just put this one up by Emily Bust because I worked with her on this when I was at UNC. And this was just recently published, but I like this study because it gives a sort of a good picture of a lot of patients. And what you can see is here's a group of patients that had one ear that was really bad. This was their single-sided hearing loss ear. And then their contralateral ear was essentially normal. And then they underwent a cochlear implantation in their bad ear. And then there's a group of normal hearing controls to compare it to. And what you see here is sort of, again, typical CI performance. You see comes in right around 60%. That's the number that you should take home from this particular talk. And it sort of should be your barometer for CI performance going forward, at least for now. And this looks at, again, single-sided deafness patients who received a cochlear implant, and it looks at their performance in noise. This is a complicated graph, but importantly, on the x-axis here is where they put noise, okay? And then this is their AZ biosentence score. This was, the gray is before they received their device, and then the various colors were their times post-op. And then the white, or the, I don't know if you call this clear, those are the normal hearing controls. And so what you can see is that if you rove the noise, we'll say to the cochlear implant side, you can see that their good ear is still their good ear. And so they're able to do pretty well. If you rove the noise to their normal hearing side, you can see that their performance obviously gets worse, but they still do better after getting their cochlear implant. Right, so you can see that their performance, even when you rove noise over to their normal hearing side, they still do quite a bit better when they have a cochlear implant in place. And if you put the noise in the center, they get similar. And so what it tells you is that they're not as resistant to noise as a normal hearing person. But suffice to say is you see a real improvement from baseline up to when they receive a cochlear implant. So a cochlear implant in your single-sided deafness ear is really helpful. It's also helpful for sound localization. And I won't belabor the point except to say that normal hearing people do really well in sound localization studies. This is that root mean squared error again. And then you see the group of patients that received a cochlear implant for single-sided deafness. And they're not quite as good as normal, but they certainly start to approach that. So the question about if you have single-sided hearing loss, whether you should get a cochlear implant, it's certainly, if your problem is hearing and noise and sound localization, it can be very beneficial for that, although it doesn't restore you to normal. And so I think this is, again, really important information as all of us are seeing tons of single-sided hearing loss patients. To say the obvious, patients that route the sound, that use cross or some other osseointegrated device to reroute the sound across their skull, They don't get any of this hearing and noise benefit or sound localization benefit. They do get a head shadow benefit, but they don't get true sound localization or hearing and noise. So this is a better outcome than what you see in osseointegrated devices or in cross hearing aid devices. And then tinnitus is also an interesting topic. We all see lots of patients with tinnitus. If they've had tinnitus and severe or a sudden hearing loss, what you can see is that their tinnitus handicap inventory scores improve greatly after receiving the device, and their quality of life also improves substantially. So with all that being said, if someone has a sudden hearing loss, especially have this screeching loud sort of jet engine type tinnitus that we sometimes see, those patients might benefit from a cochlear implant. Certainly it looks like their tinnitus handicap improves, but it certainly doesn't go down to zero. And so just to conclude here, I didn't talk actually about acoustic neuroma, but there's we and others have emerging data in the acoustic neuroma space as well. So to say the obvious, cochlear implants are really effective. They totally work. They still are underutilized in the candidate population by an awful lot in adults. CMS criteria are going to expand probably here in the next year. CMS moves really slowly, and we still have some work to do with them, but they are very happy with the results of our clinical trial. And so my sense is that that's going to become our new standard here, hopefully in the next 12 to 18 months. Beware, everybody, of noise testing in older individuals. There's nothing that is less fun than doing a great surgery and getting a terrible outcome because you chose the wrong patient. I promise you that that is not something that you want to be involved in. So beware of testing the elderly in background noise as a qualifier for getting them a cochlear implant. I will say there is one caveat. If someone has really asymmetric hearing, so they look more like the Jill First study, some people have qualified those people with asymmetric hearing loss by putting noise in their good ear, and then they drive their performance down. And so that's not a bad thought, but you just have to be honest about what you're doing and how you're doing this. EAS, asymmetric, single-sided, tinnitus are all now, I think, pretty reasonably well studied. There's other studies out there that I didn't show you that suggest that all of these indications are reasonably solid going forward. And I think, as I said, acoustic neuroma, I think, is emerging. It boils down to being able to save the cochlear nerve in a way that is viable for using a cochlear implant. Of course, the cochlear implant gives more, better frequency specific information than the ABI. Unfortunately, it's not always possible to save the cochlear nerve in a good form. So.